the presentation. Here we go. We'll be sharing out the link in the presentation as soon as it's available. And we'd like to introduce Petra Proctor, who will give us some opening remarks. Over to you, Petra.
Thank you so much, Laura. Good morning, good afternoon, good evening, everyone, and thank you all so much for joining us today on this webinar. As mentioned, my name is Petra Proctor. I'm a Senior Program Manager at Concept Foundation, for those of you who don't know me. I'm delighted to welcome you all today, and would also like to thank the Reproductive Health Supplies Coalition and the Maternal Health Supplies Caucus for giving us the opportunity to engage with you all, host this webinar, and discuss such an important topic. At Concept Foundation, our mission is rooted in increasing access to quality assured maternal health medicines and also more broadly sexual and reproductive health medicines and technologies. We know, as we know many of you do, that without quality, access is not enough on its own. Today's conversation, the idea is for it to reflect a critical part of our strategy, which is making the case for why quality must be central in achieving universal health coverage, especially when it comes to maternal health. Too often, poor quality medicines are seen as a manufacturing or a procurement issue. But this is really a systemic challenge that requires reform at multiple levels across the ecosystem, from manufacturing and regulatory oversight to quality of care to financing and government policy decisions. And crucially, it requires a shift in how we communicate the impact of substandard medicines can have, not just in health outcomes, but in economic terms. So that's what today's webinar is all about. We've taken a slightly different approach, well, quite different approach to advocating for quality by asking really what is the cost, literally, when quality of a medicine is not prioritized. To answer that question, we took postpartum hemorrhage, PPH, a leading cause of maternal death, as a case study. We developed country models in 3 countries, Ghana, Nigeria, and Senegal, to estimate the burden that poor quality oxytocin and misoprostol specifically can place on national health systems. We've published this work, and I strongly encourage you all to go and find the studies and reflect on the findings. We'll be sharing links to those. I think they were already shared in the webinar invite, but we can also share them again. And I believe the studies have already been circulated within the caucus, so you should be able to find them. But today we've chosen not to go deep into the studies and the manuscripts. Instead, we want to bring the discussion to life by hearing from those closest to the country contexts. So we will begin today with a short 10-minute overview of the methodology of the studies and the headline findings, which my colleague Sarah Rationale will provide. And then after that, we'll move into our main session, which will be a panel discussion moderated by our lead modeler, Dr. Sachi Ozawa, who I will introduce later. And the panel discussion will feature national voices, as I mentioned, who will reflect on what these findings means, the study findings, for policy, practice, and progress towards universal health coverage in their individual country contexts. So with that, I want to thank you again for all being here. We look forward to a dynamic and insightful discussion. We will hopefully have time for questions and answers at the end. So we will wait to have those then, but please feel free to post any questions that come to mind during the discussion, during the opening session, so that we can make sure to take note of them and bring them to the Q&A session. Over to you, Sarah. Thank you.
Thank you, Petra. Hello, everyone. My name is Sarah Rushwan, and I'm a program manager at Concept Foundation. And I've been part of the team who worked on this project. We're delighted to have the opportunity to showcase this important work, and this presentation will provide an overview of the modeling study we conducted, demonstrating the importance of safeguarding uterotonic medicine quality in achieving universal health coverage through case studies conducted in Ghana, Nigeria, and Senegal. This study received funding support from MSD for Mothers, as well as the Global Financing Facility and the Johnson & Johnson Foundation. Next slide, please. And next slide. Sorry, yeah. Great. So the goal of the study was to advance UHC by building the evidence base on the threat that poor quality uterotonics pose in the prevention of PPH and maternal mortality, ultimately generating evidence that can be used to advocate for policy change through demonstrating the impact that poor quality uterotonics could have. The objectives of the study were to quantify this impact in economic terms. So what's the cost in terms of extra hospital care, longer stays, or emergency interventions when poor quality uterotonics are used? And what are the out-of-pocket costs for the women and families affected? We also wanted to quantify the impact in health terms, i.e. how many cases of PPH could be avoided when quality assured uterotonics are used, and how many maternal lives could be saved. This study was carried out through a collaborative effort. So our team at Concept Foundation provided data inputs, technical expertise on the causes of poor uterotonic quality, as well as project guidance and feedback on the modeling methodologies. We partnered with the University of North Carolina, who developed the model to examine the impact of uterotonic quality on economic and health outcomes. We also worked with the University of Birmingham, who shared data from the emotive trial for Nigeria. Next slide, please. We selected the 3 countries, Ghana, Nigeria, and Senegal, based on the maternal mortality burden and the known or perceived prevalence of poor quality uterotonics based on the available data sources. And a decision tree model was developed to simulate what happens when pregnant women are given uterotonics during the 3rd stage of labor, specifically looking at the outcomes when uterotonics are of poor quality versus quality assured. This allowed us to estimate the country-specific consequences, both in terms of health outcomes and the associated costs. The data sources that went into the model included literature reviews, key opinion leader inputs, demographic and health surveys, maternal health surveys, emotive trial data, and the impact was analyzed from the perspectives of families, healthcare providers, payors, and governments. Next slide, please. So this diagram presents the model flow. The model begins with an annual estimate of the number of pregnant women. Then in the model simulation, the pregnant women faced a probability of a place of delivery, for example, hospital versus home birth, and mode of delivery. To capture some of the heterogeneity across the populations, the 6 demographic characteristics listed on the screen, including age, region, education, etc., were incorporated. We then simulated the use and quality of uterotonics, the risk of PPH and diagnosis, the associated health outcomes, and the economic outcomes, comparing scenarios with and without poor quality uterotonic use. Next slide, please. Moving on to the key model findings. So the model estimated annual cost savings of $89 million in Nigeria, $19 million in Ghana, and $1 million in Senegal under the scenario where quality assured uterotonics are used. And in terms of PPH cases that could be avoided with the use of quality uterotonics, the estimates are approximately 75,000 cases in Nigeria, 20,000 in Ghana, and 5,002 in Senegal. And these are population level estimates. We also conducted a comparative analysis across the 3 countries, standardized per 100,000 women. And this model estimated a 7% annual saving in Nigeria with 944 PPH cases avoided, 13% annual savings in Ghana with 2,200 avoided cases, and 7% savings in Senegal with 875 avoided PPH cases. These simulated results were primarily driven by high numbers of home births in Nigeria, high proportions of poor quality uterotonics and high facility use in Ghana, and poor quality misoprostol use in Senegal. Next slide, please. Here is a summary of the key findings at the population level for the 3 countries. It shows a breakdown of the annual cost savings that I mentioned, as well as the number of maternal deaths that could potentially be averted each year with the use of quality assured uterotonics. Specifically, the model estimates that 1,500 maternal deaths could be prevented in Nigeria, 100 in Ghana, and 28 in Senegal annually. Next slide, please. Taking a UHC perspective, we examined the annual impact of poor quality uterotonics on families, healthcare providers, and the government. And the highest costs were attributed to the families in relation to out-of-pocket costs from additional treatments, blood transfusions, and longer hospital stays due to the use of poor quality uterotonics. The figures here that stand out the most are the number of mothers receiving substandard uterotonics in the poor quality scenario, which is in the millions for Nigeria and in the thousands for Ghana and Senegal, as well as the percentage of PPH cases where the women had received poor quality uterotonics. So based on the data, the model demonstrates that using quality uterotonics would improve maternal health outcomes and result in millions of dollars in cost savings for the government and families in the 3 countries. Next slide, please. The strengths of the study lie in its unique country-specific case studies, which highlight the economic and health burdens associated with poor quality uterotonics. We were able to disaggregate these burdens at both the individual level and for the National Health Insurance Scheme in Ghana, and we also leveraged data from the emotive trial in Nigeria. We believe these results make an important contribution to advocating for greater investment in quality assured uterotonics as a means of advancing UHC principles. The main limitation of the study was the availability of data, specifically on uterotonic quality, usage, and costs of care. We worked closely with the project steering committee to identify the best available data sources, and while all of the assumptions were carefully vetted, the data limitations remained. Also, some data were drawn from other countries, such as the emotive trial in Nigeria, which may limit transferability of the findings to other contexts. Additionally, there were limited data to fully account for population heterogeneity in both health and economic terms. However, as a study team, we incorporated variability wherever the data allowed. Next slide, please. The economic impact of poor quality uterotonics has not been previously studied. So these case studies represent an important step in illustrating the burden based on the best available evidence. And the key takeaways from our study are: uterotonic medicine quality is critical to achieving medicine equity and improving the quality of care. Also, ensuring the quality of uterotonics can improve maternal health outcomes and result in millions of annual cost savings. In addition, country-specific policies are needed to improve uterotonic quality and realize the associated economic and health benefits. Finally, cost savings from improving uterotonic quality can support national efforts to achieve UHC and the SDG 3.1. As Petra mentioned, each country case study has been published and the comparative analysis will be published soon. So we encourage you to read and share these papers across your networks, and we'll insert the links in the chat. In the meantime, I'm happy to take any questions, and thank you for your time. Over to you, Petra.
Thank you so much, Sarah, for that overview. Hopefully that has provided you all with a good background and a basic understanding of what we did, what our key findings were for each of the 3 country case studies, also from a comparative analysis lens. We know we went quite quickly through that. So again, as I said, we encourage you to dive into the papers in your own time. Next, we will move into the panel discussion and the main part of our webinar today. Before doing so, I'd like to introduce you all to our panel moderator, Dr. Sachi Azawa. She is an associate professor at the University of North Carolina at Chapel Hill, an adjunct associate professor in the maternal and child health at UNC Gillings School of Global Public Health. She's a health economist whose work focuses on generating evidence to improve access to vaccines and quality assured medicines, working at the interface between pharmacy and public health. She's published nearly 100 articles in peer-reviewed journals conducting research on the value of vaccines, the economic impact of substandard and falsified medicines, and the threat of illegitimate online pharmacies. She and her team led the foundational work that underpinned these studies, specifically on systems mapping and linking between quality and universal health coverage. So they were the perfect partner for this piece of work. So I'm really happy to introduce Sachi and hand over to you, Sachi, who will introduce our speakers and moderate the panel discussion. Thank you, Sachi.
Wonderful. Thank you so much. We have a great panel ready for you today, representing 3 separate countries, Ghana, Nigeria, and Senegal. And we'd like to have some lively discussion. So let's get going. So I'll read the panel's bios first. We have Professor Alma Fokua Feni. Professor Feni is an associate professor at the Institute of Statistical, Social, and Economic Research at the University of Ghana. As a health economist, her research focuses on evaluating health and development programs in low and middle-income countries, with particular interest in health financing, social protection, and cost effectiveness. She brings years of practical experience, having advised Ghana's Ministry of Health and various national and international agencies. We also have Professor Chimezi Anyakora. Professor Anyakora is the CEO of Bloom Public Health. He previously taught at the University of Lagos and has extensive experience in public health and medicine quality research. Formerly Nigeria Country Director for USP, US Pharmacopoeia. He has led public health projects across multiple African countries. At USP, he directed the Promoting Quality of Medicines program in Nigeria. And now at Bloom Public Health, he advances pharmaceutical and vaccine policy initiatives across Africa and leads efforts to localize pharmaceutical manufacturing across the continent. We also have Dr. Ibno Kahing Diaw. Dr. Diaw is the co-executive director of the Africa Resource Center, where he leads public health development projects and health supply chain transformation across Africa. With over 15 years of hospital experience and a decade in public health supply chains, he has partnered with many global organizations, and his past roles include supporting vaccine initiatives and national health program development, focus on resilient health systems and the right to health for all. Welcome to the panelists, and thank you for joining us today.
Sachi, you're a little choppy. I'm not sure if others are. We could generally hear you. You're a tad on the choppy side. Perhaps you might want to turn off your camera if it's competing with your connection.
I'll turn it back in for that. Great. Let me go ahead and start with some of the questions then for our panelists, and hopefully we can get the conversations going. We first have a question for Professor Feni. What are your top 3 level takeaways from the modeling study in Ghana?
Thank you very much, everyone, for joining us today on this panel. I must say that I was part of this process indirectly because I was on the board, and I saw the challenges that our authors went through to get to this point. So a big applause to everyone on the team. So again, looking back on the study and reflecting on what was done in Ghana, you recognize the fact that this is very unique in the way that it blends both epidemiological modeling with economic insights. And so you read the paper, you read the results, and you're able to look at how these outcomes translate to a broader picture. So in Ghana, we have currently what we call the Ghana Health Sector Medium-Term Development Plan. And one of the goals within this plan is to reduce maternal deaths. And so again, this is very timely. These results for advocacy comes in very timely. We also see the fact that the quality aspect of these commodities that we have on the market becomes very, very important for maternal mortality. In the Ghanaian paper, for example, they show that about 20,000 postpartum hemorrhage cases and 107 maternal deaths are due to these poor quality uterotonics. And for me, what it draws attention to is the quality aspect. And many times when we talk about maternal health, we forget that there are so many different factors that drive these numbers. And unless we have studies like this, it's very difficult to see. And so we are looking at quality and we are also looking at financial protection. The paper also draws attention to the fact that not only are these poor quality medical products, but they are also affecting households on a very different level. So you have all these huge high out-of-pocket payments, and households are burdened by that. Beyond these, we also have the broader economic issue that comes out of productivity loss. The fact that all these women who have to suffer these cases are not able to be productive citizens, and therefore we lose as an economy and indirectly. And so I really appreciate what this paper has done, linking the health outcomes to economic issues that we need to pay attention to. Yes, we want to get to UHC. Yes, we want to get to our SDG goals by 2030. But there are factors that we need to consider. And beyond this, I think what this paper does is to move us to look at the bigger picture. So we have issues around regulation. Who is regulating the supply of these poor quality products? What is the role of the Ministry of Finance? What is the role of our Food and Drugs Board authorities? What is the role of regulatory authorities within the sub-region, not just in Ghana, but in West Africa as well? So I think there are lots of takeaways from these papers, and it's very key for us to know how to push out the messages in a way that we can get everybody on board. So it's not just a Ministry of Health problem. It's not just a Ghana Health Service delivery problem. It's a problem for every part of our economy, and we need to draw attention to that. So I hope that as the dissemination efforts go on, we will pick up these key messages and push them in a way that we can get everybody on board. We need to pay attention to quality. It's not just for our health sector, but for every part of our economy. I think I'll leave it here, and then I'll come back with other ideas I get from the paper. Thanks.
Great, thank you so much. Let me then move on to another question for Dr. Anyakora for Nigeria. What were your top 3 kind of takeaways from the model study in Nigeria?
Thank you so much. Thank you everybody for joining this. For me, this study is so unique because it somehow crystallizes the effort in the past few years to understand the impact of poor quality uterotonics. I mean, in the past 7 years or so, we've been doing some work, but this particular research work brings it to 4 and is a kind of a strong advocacy tool. Right now in Nigeria, as you all know, Nigeria has the highest maternal mortality rates, the highest in the world. And we have a minister right now who is taking it seriously. So I see this paper as something that can probably move the needle if we really utilize it well. Without trying to repeat what Professor Fanny has said, there are 3 points for me I want to push out from this. Loss of life, cost to families, and impact on UHC. Let me just briefly go through them to see that from this paper, we are identifying up to 77,000 lives can be saved if we have, if we remove substandard uterotonics from the markets. That's a huge one. It's a specific ask, knowing that this is the impact, the number of lives lost, and Nigeria being the highest in the mortality, which means that if we focus on solving this, we can move from being the highest to somehow in the middle. The second one is cost to families. I think Nigeria is among the countries where you have the highest out-of-pocket spend across Africa, because we have very low health insurance coverage. So most people spend out of pocket. So imagine the cost to families if they have to spend this. The last one is the cost UHC. Sometimes you don't understand that the fact that if government is going to spend so much money from this study, over $89 million will be saved if we don't have substandard oxytocins in the market. So imagine if that money is available and utilized to support the health system, we can cover much more people. So really, I'm hoping that with this paper, coming at the right time, with the right leadership in Nigeria, with the right statistics, everybody is now crying to stop. I'm hoping and believe that we're going to make quite some advocacy, fruitful advocacy to move the needle. So let me stop here so I don't repeat what Professor Fanny has said. Thank you so much.
Great, wonderful. Thank you so much, Dr. Enyakora. Let me move on to Dr. Diao. What were your top 3 key takeaways from the model study in Senegal?
Thank you very much. Hi, everyone. And thanks again for giving us this opportunity to myself and also to my organization, which is Africa Resource Center for Healthcare Supply Chain, to be part of this panel. I think that's the point his colleagues raised, especially Professor Feni and also Professor Ami Okora, are very relevant. And when we are taking the case of the Senegal, I think that for me, it is the uniqueness of this work that you have done is talking to us. When we are working on the healthcare supply chain, the first is we are supporting government for implementing and achieving their objective to ensure that we have all those health commodities are available along the end-to-end supply chain. But the challenge that we are facing now is when we are talking about quality. I think that there is 2 things. The angle that you are analyzing this challenge of the poor quality of those uterotonics makes sense. The second one is how relevant it is, because the economical point of view angle makes sense also is talking to those decision makers. Especially, we used to utilize data, epidemiological data or technical wording for telling things. But now the way that we are shaping the narrative is totally different in this economical angle of view, and that speaks to those decision makers like the Minister of Finance in our different countries. It's yes, life savings. It's totally different when we are saying that the prevalence of the deaths of the PPH in the population. Sometimes, yes, as a technician, we can appreciate those figures, those numbers, but for a decision maker, like at the ministry level of the Minister of Finance, they don't talk to us. It means sometimes nothing. I think that it is where I really appreciate the way that those analyzed was that was analyzing for supporting the institutional advocacy for getting those quality. But now, also the second point I would like to raise is when we are talking about quality, is that raise that because, as you know, since COVID-19, we realize, we wake up understanding that most of those health commodities was not produced, especially the pharmaceutical goods, was not produced in the continent. What does it mean? It is less than 1% when you include all those commodities, including vaccines. It means that when we are talking about sovereignty and quality, when you are not producing or manufacturing what you are looking for, your needs, to address your need, it is very difficult to manage the quality from the manufacturing to the bed to the pay of the patient. I think that's very important now when we are talking about local manufacturing to pay special attention based on those studies on the quality. And that brings me on the last point that I would like to raise is one is the integration of the cold chain. When we are talking quality of those products, how could you, what should we have or could we have under control? Especially for me, I'm thinking about the cold chain. How could we now integrate this cold chain? Because we can't have this difference, because this cold chain should be utilized for immunization program or immunization product, and this one is for maternal and child health. It doesn't make sense. I think that this integration should happen in the different program and should be led also by the government. We can have this cold chain. Immunization have a good story and that give strengths how on managing the cold chain. How could we strengthen or leverage on those strengths to improve the quality of the storage of those medicines to ensure that the quality. The next, all the steps now is in the procurement level, from the manufacturer. How could we? I think that having a very strong regulatory authorities in the different countries and also monitoring the quality of that based on those results that will help us to make all those saving and especially saving lives. Because where I'm coming from, especially in Senegal, we say there is no cost for life. We can make this exercise for costing life, but there is no cost, especially for those women who are our sisters, our mothers, our wife, and giving dying because just trying to give life to give lives. And I think that for me, I will pause here. And thanks again for this opportunity. It is just 2 or 3 takeaways that I have on that. Thanks, Dr. Shaik.
Great, wonderful. Thank you very much, all of you, for sharing the top takeaways from the study. I'd like to go back to Dr. Fenny and do another round. What value does the economic impact modeling offer for you, Dr. Fenny, and how can the results inform strategies in other low and middle income countries facing similar issues with uterotonic quality?
Okay, thank you very much. Yes, so I do take, I appreciate the fact that you have attempted to do something that hasn't been done at all, modeling just one aspect of obstetric emergency care. But I must say that it draws attention to what the broader picture looks like. So it's not just uterotonics that we are having issues with. The picture shows that there are other indirect factors that drive this whole quality issue. So in the broader sense of the word, there are other factors, multiple factors that drive maternal deaths. And yes, this could be one of them. And we appreciate the fact that this paper actually does that. It gives us an opportunity to say, let's go back and look at how this links up with other issues within our systems. And this is not just for Ghana, it's for all the other countries that have been part of this study. So this modeling allows us to look at other factors. What are the multiple factors that make this a problem? So there are several factors when it comes to emergency care for women. We need to be able to pick these up. One of the issues that I had when we saw when we started this process was the fact that, yes, we have these national level statistics, and it is very good in terms of what it's able to say on the national level. But what it does also is that it masks what happens at the subnational level. So if we're having these problems at the national level, let's think about the subnational level issues, where we have equally difficult terrains to deal with, hard to reach areas, rural areas that don't have any chance to even see what a uterotonic product looks like. So the subnational issues could be even worse. And so this modeling gives us a tool to start the process of actually drawing attention to what this problem could look like, even at the subnational levels, where they don't have access at all to these products. So I think the modeling has been a very good initiative. It draws attention to the fact that this is not just a problem for the health sector, as I said before. What are we doing about regulation in the sub-region? How can we involve the blocks, so ECOWAS, West African Health Organization? How can we get everybody on board so that we can use the results of this tool to start making inroads to the key areas that we need to look at? So it's good. It is a good step in terms of what we've been able to achieve with the results, but I think we can push further. Yes, it's been challenging to get data, but I think what we have is good enough to start working with. But it opens our eyes to what the issues are. The issues are much, much bigger than just looking at this particular aspect. So I hope this is just the beginning and not the end. And as we reflect on today, we'll go away with something that we can work with as a region and across Africa as well. Thank you.
Great, thank you so much. Let me move on to Professor Anyakora. In what ways can advocacy efforts support stronger safeguards for maternal medicine quality within the Universal Health Coverage Agenda?
Thank you much. You know, one thing that this paper is bringing out, it has widened the scope of its stakeholders. I was involved in a few research work on quality of oxytocin and misoprostol in the past. It somehow narrowed it to regulators or to some kind of different, much smaller scope of stakeholders. But this one somehow addresses everybody, the families, the finance institutions, everything. And also, I like the weight of the figures that are being brought out. Every human being on planet, once we hear that something can actually avert up to 77,000 deaths, I mean, it's something that appeals, attracts. What can we do? That's a call for action. From government point of view, with a very minimal budget, knowing that $89 million will be saved and channeled to something else, it's also something that attracts. So really, from that point of view, I think this paper is a very, very strong advocacy tool to reach out to so many people, because the effort in the past failed because you reached to a narrow scope, technical people who have little impact on the overall decision being made. But with this paper, and also with the timing in Nigeria, is something that we have to really milk very well to achieve maximum impact with it. We have the right minister around now who sees it as a priority. We have a lot going on in the health space in Nigeria. So in summary, I think this paper, we need to push it more. It is something that we have to translate from a technical paper to messaging that appeals to everyone. So, and if you have such a compelling tool, we should use it well. So specifically, I'm hoping that there will be a lot of town hall meetings, engaging the right stakeholders, how to, even at mass media's level, everybody in Nigeria should hear this. Everybody is a kind of a stakeholder in maternal mortality. Everybody who knows that someone who has died giving life. It's such a, it's such a graphic thing everybody can attest to. So I'm hoping that we move this forward to see how do we reach out to many more people? How do we make sure this paper doesn't end in academic circles? I will translate it. So the summary is I want to translate this paper to the people that need to hear it and see the impact it can get. Thank you.
Wonderful. Thank you so much. Let me move on to Dr. Dial. You were mentioning earlier about the importance of strengthening cold chains. How can decision makers in low and middle income countries better utilize cost effectiveness data to inform the supply chain and procurement strategies aimed at eliminating substandard medicines in maternal health care?
No, thanks, Dr. Saki. I think that it is very important that the point you raise. And for me, I was just taking the part of this quality chain, which is a part of the quality when we are talking about the quality of those products. Even most of those products are very sensitive with a high temperature, has a high temperature. I think that for me, at the country level, it is from the procurement side. Those information should help and should lead decision from the procurement side to all those segments of the supply chain until the bed of the patients. Does that mean that for the health workers? Does that mean that it is an advocacy, a very power advocacy tools for the decision maker, but also for the health workers, because we need to pay attention. For all of us need to know what are the consequences of our negligence. If negligence are in during the storage, during the transportation, and all those supply chain, let's say all those stakeholders around this process for getting this product. I think that Professor Feni talk about it is just maybe the top of the iceberg of that, because there are many other issues. And where we are now, I was talking about also the challenge that we are facing, and she raised a very important point when we are talking about local manufacturing, when we are talking about procurement. As you know that we are very split small country. Maybe Nigeria doesn't have these issues, but the issues is for the other countries because they have the demographic weight for going on the procurement. How could we utilize those regional bodies like WAHU in ECOWAS or another organization in COMESA or in SADC or any other organization to go on those kind of mechanism, what we call that the pool procurement? But when we are procuring, we need, these studies are talking to us that we need to have in mind also the quality of the product. Quality of the product, but how could we get the quality of the product? Which kind of mechanism or regulatory or mechanism should we put in place to ensuring that the quality of the product when we are procuring from the manufacturer in countries? And in countries, how could we ensuring also the quality of the product in the alongside of the health pyramid, from the central level to the service delivery plan order to the facilities, health facilities. I think that there are very critical decisions, and in my point of view, there are those points that in countries there are those organizations that we need to implement to set up to ensure that the quality from the procurement in and from the and all those and the regulatory side in countries. There is also, regarding the challenge that we are facing with our small countries, we take the case of Benin, very close to Nigeria, Benin, or you have Togo, they are very small countries, or Senegal, even for my, it's a volume the volume that of our need for ensuring the quality of those products is very problematic. That's why I think that thinking about in the economical perspective, how could we be affordable, being able also to manage the quality of the product from the manufacturer in country, and how are we organizing the supply chain, the distribution in countries. It is also something very important that, in my point of view, we need to think about and to influence also the decision maker having the right policies in place, and also the funding. Because don't forget that most of those fundings are coming from the development aid. Mobilizing the domestic funding that give us the authorities and the autonomy for ensuring that also the quality of our product. You can't talk about quality when you don't have the control, all the process under control. But if it is just based on the demand of the development aid, it will be very difficult to have your voice to have your voice counting on that point. And it is the main challenge for our countries, and also especially for our government. And I think that at the end, I will pause here to say that for me, the key issues is in-country regulatory, having a very power and strong regulatory agencies in countries, and having also the procurement policies in place and very strong from the manufacturer to country. And in countries, how could we go together on the pool procurement, implementing the pool procurement mechanism, and having also this control along those countries, like Professor Fomi says. And yeah, I will pause here, and I think that it is what I would like to share, responding to your question. Thanks. Over to you.
Great. Thank you so much for all the panelists' contributions to this and kind of contextualizing what the study actually means. We have a final question for all the panelists, the same question. What steps can national stakeholders take to apply these findings in their local context to improve medicine quality and maternal health outcomes? Maybe we can go around about again on this specific question. Dr. Fenny?
Yes. So thank you very much. Coming up from what Dr. Diao has said in Senegal, you might think that there's no way we can do this in our countries because it will take a lot of money to build the capacity of our regulatory bodies to be able to, ensure that we have good quality product coming into our countries or even being manufactured locally. But we do have, at the very least, community health workers, our midwives who are trained. If we can, train them to report when they're dealing with these cases. If we have the training done in such a way that they can actually report that yes, these products are substandard, then it will draw attention to this at the very subnational level. I'm drawing this up because many times we are talking about the big things that we need money for, but we can pick up on local surveillance for reporting some of these cases and helping move the needle away from, supply chains being clogged by poor quality substandard products. So let's use what we have now. We have decentralized systems. We have our community workers who can pick up on these issues and draw attention to them. Let's start using these avenues. And yes, we want to ensure our regulatory bodies have what it takes to ensure that we don't have these products coming in, but they will come in. They will come in. We need to start finding ways of short-term goals of meeting the demand of these quality issues. So I think I leave us to think about how we can localize the strategies around these poor quality products coming into our countries and move on from there. Yes, we want African medicines agencies to work quickly. We want all countries to ratify this so that we can have that, big agency moving across countries. But it takes us citizens who care about our mothers and our daughters and our wives to make the difference. So if a midwife has seen that, no, this product is very bad, that midwife should be able to report it. We need to have that chain in place. And then as the system improves, as we move out and clear out our health system of all these bad products and send the message out that we have surveillance in place locally. So if you bring these products, we will put you we'll put you in jail, something like that. We need to send strong messages out so that we stop these products being used at the very local level. I hope these results will not stay on the shelves and we can really use it as an advocacy tool, as all of us have said on this platform. So thank you very much for working hard to get these results, and we hope it will do a lot of good for us in maternal health in Africa. Thank you.
Thank you, Dr. Fenny. How about you, Dr. Anyakora?
Thank you so much. For me, just also echoing what Professor Fenny has said, But I want to disaggregate the stakeholders. First, the regulators. I believe that with this clear message of the paper, they have to impose stricter regulation, really, because they are the safeguards of the medicine quality in any country, and also general public. You know, medicine quality is not the preserve of just regulators, it's everybody. As in fact, Professor Fanny captured it well. If we all know the impact of this, both economic, health-wise, we all see that we are stakeholders. So if you see something, you say something, really. That's one of the points I want to make here. And finally, the supply chain system. Really, most times, we over-regulate manufacturing and ignore supply chain and distribution in Africa. The effort they put to regulate manufacturing, GMP, PQ, and co. And when it gets to a country, nobody thinks about it. From my field, I realized that most of the quality issues they have in medicine across Africa is supply chain issue. So if you fix it, we'll fix a lot. So really, I'm hoping that with this, the people who run and manage and regulate supply chain see that this have a very important role to play to safeguard the lives of our mothers. Thank you so much.
Wonderful, thank you. Dr. DL?
Thank you, Dr. Sagi. I think that my colleagues, especially Professor Fanny and Professor Ayankora, have said I think that they raise a main point. And Professor Femi, thank you very much for this. I think that you raise a very important point in terms of surveillance, ensuring that for those substandard products. I think that I'm not sure that now we are training and supporting some government for changing policies for the pharmacovigilance. I think that it is a part of the pharmacovigilance that we need to integrate the quality of the product. We are just more talking about the reverse, the side effect, but not about the poor quality of this, which is part of the side effect. I think that it is something that we need also to put in place this instrument and to update those forms for the pharmacovigilance. We take note on that. And I think that for the takeaway and the decision that we need to influence at the definition government level for advocating, it is some point that I will take over on that, ensuring that it will be implementing and integrating in the pharmacovigilance form. And I think that Professor Anio Kora, what you say makes sense. Supply chain is not monitoring and there is no surveillance. We have some KPIs. We are working with several metrics to ensure that the quality of that. But what we forgot sometimes that supply chain is coming from, is not native to the health system. It's not bad. That's why it is the reason of my organization. The reason of my organization is positioning the healthcare supply chain in the health systems. It is a support function, and people was looking at that as a support function, but not as a critical function for that. And that's why when we are talking about the professionalization of the supply chain in the health system, it is what we are talking about. Without product, without health commodities, there is no services. And when we are talking about supply chain, first we are talking about the quality also of the product. And thank you for recalling that this point. But I think that is very important. And for us, positioning, I think that for me, the last point is for this quality is having, as Professor Femi is suggesting, these surveillance systems regarding those substandard. The second point is what Professor Anio Kora is saying is regarding the positioning the healthcare supply chain and ensuring and having all those metrics for monitoring the performance of this of the supply chain commodities for the healthcare commodities, ensuring that we are in the right track. Thank you very much. I will pause here and thank you also. Thanks again, Dr. Saki. Thank you.
Thank you so much. Let me pass it back to the Concept Foundation for Q&A and closing remarks.
Thank you, Sachi, and thank you so much to our panelists. I know we are a little over time, so I'm going to jump straight to a question that was posed, a great question that was posed in the chat. I don't know if you were able to see it, Sachi. I've already answered some of it by replying in the chat, but the question was asking how we were able to isolate the issue, the impact that the quality of uterotonics can have on a PPH outcome, given, as I think all of our panelists has raised, in particular you, Dr. Fenny, that it's PPH outcomes are caused by a number of variables, one of which can be the quality of the medicines used to both prevent and treat postpartum hemorrhage. So the question was, how did we isolate the specific impact of quality and take into account the potential confounders that can impact a PPH outcome? That was the first part of the question. The second was specifically on insights around Ghana's experiencing and leveraging EPI cold chain for uterotonic storage. So we'll circle back to that one. But on the isolation piece, I shared that and I'm going to ask you, Sachi, to jump in and feel free to add to this, but essentially we modeled a baseline scenario where the assumption was that substandard uterotonics were used, and then we modeled another, and it was not me, it was Sachi and her team, modeled a scenario where there was an assumption that all uterotonics were assumed to be of adequate quality. So by holding all of the other model inputs constant, we were able to isolate the difference in outcome. So we also applied an empirical risk ratio that was calculated using real-time data from the emotive trial in Nigeria. And there were other study countries as well, but we specifically used the Nigeria data to calculate risk ratios to be able to associate the impact of quality with the use of substandard quality uterotonics and the impact on PPH. So Sachi, I don't know if I've done a good job of explaining that in a sort of very crude way. And if you have, if you're able to, it'd be great if you could add to that in terms of adding a bit more detail to the first part of the question. I don't know if you're in a position to answer a bit more on the second part around cold chain as well.
Sure, I'll keep it really short. So yes, it's the difference in the scenarios, just changing the quality only that allowed us to look at the impact of quality, and keeping everything else like shortages, care seeking patterns, all of those things constant. And if you'd like more details, please read the papers. I hope that would answer your question. And then Dr. Fenny, let me pass it over to you to answer the question on Ghana.
I don't have details on what our cold chain looks like, but I know that UNICEF and the Ministry of Health and the Ghana Health Service are constantly monitoring our cold chain to make sure that we keep these products under the ultimate conditions for them to be able to meet the needs of our mothers. But again, there are challenges that we deal with. But these are the agencies that are working constantly to make this work. Yes, thanks.
Thank you, Dr. Fenny. I believe we are at time. So I'm not sure if I don't think we can proceed with any more questions, but there's an additional question noted in the chat that we can try and respond to in follow-up to the webinar. So I'm going to wrap up today's webinar with some closing remarks. But again, first, I want to thank all of our speakers, our moderator, Dr. Ozawa, for such a thoughtful and engaging discussion. And thank you all to the audience for taking the time to be with us today and for your insightful questions. To the point made by, I think, most of the panelists, we really see this work not as an end, but absolutely as a beginning of a broader effort. We also 100% recognize that the quality of medicines is one part of a bigger ecosystem and a bigger collective effort that needs to happen across a health system, really, and that we also need to be able to think about that at a global level, but regionally and also nationally as well. And it's complex, excuse me, and it's going to be a mountain to climb, but it really is our hope that this work serves as a tool and as a first, not a first step, but an additional step in the forward momentum. We do hope to be able to expand this modeling approach, improve on it as well, both in terms of different health areas that we could examine, but also country contexts to engage with, and potentially examining those other confounders as well. Our goal is for this kind of evidence to become a powerful tool that countries can use from within, really, to advocate for reform, influence policy change, and ultimately ensure that investments in quality of medicines, quality of care, and beyond are recognized as fundamental building blocks to really establishing resilient health systems and effective health systems. Because really, I think the underlining message is that not investing in quality across the board is only going to be a false economy. We're also really excited to share that we have developed an interactive PDF, which is going to be a sort of advocacy tool that really synthesizes the outcomes of the studies into something more digestible, that isn't, is a little less technical than the manuscripts. So we'll be launching that in the next month or two. We'll be inviting obviously everyone on this webinar and disseminating further. So we're looking forward to sharing that with you all. And we really hope to continue this important dialogue and ensure that we continue to commit to every woman and everywhere having access to quality assured maternal health medicines. So thank you all so much. We wish you all a wonderful rest of your day. I put my email address in the chat, but you all have access, I think, to us through the caucus. So if you have any more questions for us, for our speakers, then please do just let us know. We're happy to keep talking by email or to jump on a call and discuss further. Thank you all so much, and goodbye. Thanks.
Thank you. Bye, everyone.
Thank you. Bye.
Thanks.